can be due to this dystonia. You might have difficulties using the hand. That could also be a dystonia. Rare tremors can be caused by dystonias. So what causes dystonia? Well, it's easy. You either are lacking medication for Parkinson's, or you are having medication side effects. That's basically it. You either need more medications for your Parkinson's, and by taking the medication, the dystonia is going to get fixed. Or, sometimes you cannot take more medication for the Parkinson's because you will get side effects from that medication. But still is what we would call an off dystonia, meaning if we would be able to give you a better treatment for your Parkinson's, the dystonia would go away. That's an off dystonia. You could also have an on dystonia, meaning that as you need medication for your Parkinson's, we'd give you the medications, and one of the side effects from those Parkinson medications would be to have dystonia. So as you can see, it's complicated because we could be giving you more medication to try to fix it, and in fact, that's going to make it worse. So we need to be very careful on how we approach this problem. The dystonia treatment then is divided into 4 quadrants. The first and most important, and the most, the one that most of our patients need to do, is physical therapy and occupational therapy. That is the foundation for the treatment of not only dystonia, but also Parkinson's disease. Then you have oral medications. So if physical and occupational therapy are not fixing the symptoms, it means that we need to add medications by mouth to fix it. If those don't work, then we start thinking about shots, injections. And if those injections don't work, then we consider surgery. So this is a patient of mine, and on the left-hand side, you're going to see the patient on weeks 1 and 2 after receiving Botox injections. So on weeks 1 and 2, you see that the patient he's taking this picture trying to open the eyes as much as he can. But as you can see, he's not doing a very good job at it. But then the pictures on the right are the pictures after the treatment has started working. And as you can see now, the patient is able to open the eyes properly. So botulinum toxin injections are a great option for patients with dystonia because they don't go to the brain, so they don't give you brain side effects, and they work extremely well for dystonia. The medication kicks in within a week or 2 after the shots. As you can see there on the bottom picture of the week 2, the eyes are a little bit better already than on week 1. So it kicks in within a week or 2, and it works for about 3 months. In some patients, it works all the way to 6 months. In some patients, it works for 2.5 months. But overall, the patients feel that it's an okay deal because they're coming to clinic maybe 3 or 4 times a year, and their dystonia symptoms are being fixed. How many people we have here who receive botulinum toxin injections? All right, yeah, we have a bunch. Very good. And the way it works is that, again, dystonias are underdiagnosed, and therefore they are undertreated. I'm going to show you here another common problem in Parkinson's disease, which is anterocolis, which is when the patient's head is looking down to the floor, or camptocormia, when the entire body is bending forward. So in the first patient here, we have an anterocolis. The neck is looking down. The head is looking down. And after the patient receiving botulinum toxin injections, you can see how the patients are looking better. The other one is camptocormia. So now you have the whole trunk is deformed and looking down, and after injections, the patient's posture has improved. So these medications can be truly miraculous, and is something that we really need to work on to try to help our patients better on identifying these conditions and providing appropriate treatment. As the disease progresses, we start developing what is called motor fluctuations. At the beginning, when a patient has Parkinson's, you start the treatment and they feel great all day long because the medication is working continuously. As the disease progresses, the medication doesn't work for a long number of hours, many hours. It works for a short period of time, so the patients get better and then they get worse. Levodopa, hands down, is the most effective treatment for Parkinson's disease. However, we have many new options. So we had selegiline, Harlodel, Apoquine, Pen, Mirapex, Requip. And each year we add more. So those that I showed you were the ones available when I did my fellowship 14 years ago. And now we have, look at this, Comtan, Parcopa, Stalevo, Nupro, Mirapex ER, Requip XL. And now, over the last few years, we have added Rytary, which is a long-acting carbidopa-levodopa formulation. We have added the Apoquine pump, and that's still on the works. We are also investigating a levodopa subcutaneous pump that is going to work at some point. We have added Duopa, which is that pump on the right. We have added this very amazing new way of delivering levodopa, which is Imbrija. Is an inhaled form of levodopa that patients can use on demand. So they carry this with them, and as soon as they are feeling off, they pull it up and they inhale it, and the medication starts working within 10 minutes. I have so many patients who suffer because they don't want to leave the house due to the unpredictable nature of the disease. And there are many ways of fixing unpredictability, and I'm showing you guys here a number of them. And Sadago came to the market about 4 years ago. So again, we keep on adding more and more medications. And what we're trying to do is to keep our patients in the on state. So when the medications are working, patients are on, and when it's not working, they are in the off state. These medications are great, but they can have some side effects. These kinesias, the wiggly movements that some Parkinson patients have, can be a side effect from medication. And we were reflecting, the faculty in the back, we were reflecting during the morning how amazing it is that 10 years ago, we would look at not the same crowd, but some patients with Parkinson's disease in the symposium, and half of them would be wiggling all over because of these kinesias. And now we were just so amazed that because of the many advances on the treatment, we are able to provide benefit without having terrible dyskinesias. But that's a common side effect. Now they are mild. They are not as severe as they used to be. But there are many other complications. So the patient gets up in the morning and the Parkinson medication is not working. They take it at that time and the symptoms go away, and now the patient is in the on state. But then it lasts for a while and then the symptoms return, and now we are in the off state. So that's what we call motor fluctuations. And these fluctuations vary depending on the time of the day, and also vary depending on the stage of the disease. So when the patient is on the early stages of the disease, the medication starts working and it works for the entire day, and the patient goes to bed and the medication stops working. So the patients they don't realize any fluctuations of benefit during the day. As the disease becomes moderate, then we start having what are called predictable fluctuations. So I take my medication, I know it's gonna kick in within 20 minutes, half an hour, and then it's gonna work for 2 hours, and then I know I'm gonna be off again. So moderate PD, you have fluctuations that are expected. And then advanced Parkinson patients start having problems with unexpected behavior of the medications. So, for example, they might take their pill and ask themselves, did I take it? Because it doesn't seem to be working right now. They might have what is called dose failures. They might have severe side effects from the medications that they took. And these kinesias are more prevalent in this particular timing, and the patients are taking medications a lot more often. So what do we do? Because there are many treatment options to fix all of these problems. Every year, we work on so many clinical trials trying to fix each and all of these problems. And we're very busy, not only trying to find a cure for Parkinson's disease, but also trying to find best treatment to all of the symptoms of the disease. So the motor fluctuations can be predictable, unpredictable, off, sudden off. Sudden off is a big problem. Like the patient is doing fine, and within seconds, then everything stops working. So living that way can be really problematic, but there are ways of fixing this. Also, the duration of off can be prolonged, and I talked already about the motor dose failures. So we need to consider advanced options, including surgery, once the motor fluctuations or the dyskinesias start occurring. And there are many good options for all of these. So what would be the expected benefits from surgery? Well, the expected benefit should be that we want the patient to stay on longer without the side effects from the medications given by mouth. How many patients here have deep brain stimulation? Right, we have a number of hands raised. How about Duopa pump? Very good, very good. So that's the expected benefit from the surgery, is to be able to be on longer without the side effects. Duopa is a pump that delivers levodopa gel into the stomach directly, in fact, into a part of the intestine called the jejunum. And by providing the medication continuously, it allows for no motor fluctuations. It also is very important for everybody to understand that levodopa is absorbed in the jejunum, and therefore it has to pass the stomach. The issue is that patients with Parkinson's disease, up to 80% of them, have difficulties with stomach emptying. So the pills are just lagging behind in the stomach. You swallow them, but they're not being absorbed. With Duopa and with other advanced treatments, you can actually bypass the stomach slowness and produce a level of absorption of levodopa that is more leveled and that continues. So therefore, you don't see the fluctuations. In the Duopa pivotal study, the Parkinson's symptom diary analysis showed that at baseline, the patients were having about 6 hours in the off state. And the on time without troublesome dyskinesias was 8.7. And the patients ended up gaining an average of 4 hours of on time. So, imagine gaining back 4 more hours into your day. This is why these options are so extremely powerful. Duopa, the most common side effects have to do with GI problems because you have a hole in the stomach. It's like a feeding tube, and therefore that, most of the side effects are related to that. I just met one of my old mentors at WashU, and he told me something that I'm not sure if it's a good joke or not, but I will repeat it. He said, Diego, he's a funny guy, but he said, Diego, once the patients with Parkinson's disease get into the advanced stages, they need holistic therapy. And I said, holistic therapy? I agree. We need all options. We need physical therapy. I was like, no, Diego, you are not getting it. They need either a hole in the brain or a hole in the stomach. So that's advanced treatment for you, holistic. It is important to recognize that with Duopa treatment, most of the side effects are seen within the first week of treatment. So as you can see on this picture, most of the side effects are seen within the first 2 weeks of treatment, and after week 2, the side effect profile is really reduced. How about deep brain stimulation? The indication for deep brain stimulation surgery is when increasing medication dosage is needed. You need more, right? But by giving you more, you get side effects. That's the indication for deep brain stimulation. And there are a number of examples. One could be somebody with 15 years of disease taking levodopa all the time. Levodopa improves the tremor, but it's causing terrible dyskinesias. Well, then DBS would fix that problem. The second one would be a patient with, say, 10 years of disease. Freezing of gait goes away with levodopa, but then cannot walk because of the dyskinesias and the leg cramps from the treatment. So the levodopa helps you, but it also causes side effects, and therefore you end up not walking. That would be a good way of, one way of fixing this is with DBS. And how about a patient who is taking extremely high doses of levodopa and all possible medications, early disease, but the tremor is not going away? Well, the only fix for that is actually deep brain stimulation surgery. So there are many more examples that I could give you, but basically, as the disease advances, DBS is also an amazing option for you. We have a DBS evaluation protocol at UNMC that starts by an evaluation at the Movement Disorder Center by a movement disorder expert. And that evaluation is going to help us understand what type of Parkinsonism the patient has, and if the issues are better fixed with DBS or better fixed with something else, because there are so many treatment options. Many patients that are sent to be seen at the DBS center end up not getting surgery. They end up getting other treatment options. Then after that, the patients are seen by the brain surgery team, and we also perform an inpatient evaluation of all of the symptoms in the medication off state and then in the medication on state. And then we meet together as a team, anywhere between 10 and 15 people, and we discuss every case individually, and we provide a single recommendation at the end of that meeting back to the patient. And the recommendation could be, yes, DBS is good for you, or no, DBS is not good for you, but this is what you need. And a third one would be, DBS might be good for you, but not right now. We need to wait, and we need to try these other options. Once you get the surgery, then the patients need programming of the device and continuous monitoring of the drugs. The surgeries are extremely effective and safe, and the risk of these procedures have to do with brain problems. So if the surgery in the stomach was giving you stomach problems, well, the possible side effects from deep brain stimulation, the one that we are scared the most would be a bleeding during the surgery. And that occurs in anywhere between 0.5 to 2% of the population in the United States who receive deep brain stimulation. So it is rare, but it's a possibility, and we need to keep that up front. The good news is that our surgeons have not done 10 surgeries or 100 surgeries or 1,000 surgeries. Our DBS surgeons, and we have 2, they have done multiple thousands of surgeries of DBS. And Dr. Follett has published the largest studies on deep brain stimulation surgery ever published in the United States. So we have immense knowledge of DBS and how it works, and we think that that's why we have great results. And here you have a patient who underwent deep brain stimulation for severe tremor that was not going away with the medications. And you can see how she's in the OR and she's awake. because that's how the surgeries are usually done. And you can see how happy she is. We're testing for tremor when she's approaching the cup to her face. And you can see how she has no tremor whatsoever. Do you see any shaking? No? No? Okay, good. And with that, I finish. Thank you very much for your attention. I look forward to the questions. Thank you for being here. Thank you very much. Thank you.
Thank you so much, Dr. Torres. And there will be DBS questions that you guys have already identified on the cards, and he will complete those with the next question and answer session. Next, I would like to introduce to you Dr. Danish Bhatti. He is an assistant professor at the University of Nebraska Medical Center Neurological Department, and he is also the co-director of our Comprehensive Movement Disorder Clinic. He is, and by the way, our comprehensive Parkinson's disease clinic is the only one in the state of Nebraska. Furthermore, Dr. Bhatti is going to speak on research with Parkinson's disease. I truly do believe in the bottom of my heart, and I have told many of my patients this, when there is a cure to Parkinson's disease, this guy's name will be associated with it. Please welcome Dr. Bhatti.
All right. Well, so when I go internationally and talk and present, they ask me, what do you do? And I say, I'm a single disease doctor, because I only see, treat, research, teach one disease, and that's Parkinson's disease. There's so much to do just in Parkinson's disease, and as you will see, that although my primary interest is in managing the disease and educating, there is so much to be done in research. I typically try or hate standing in one place. I freeze up, it's too cold. But I have to, unfortunately, today because we're recording some of these sessions, so I apologize. My hope today is to give you the hope for the future. So a lot of patients come to me and they ask me what's new, what's going to happen, and I usually tell them that I think that we'll have something to slow down Parkinson's within the next 3 years, and I think we'll have something that will significantly improve or reverse Parkinson's in less than 10 years. And and I make those guesses or estimates based on what I read in the literature, what I see at other conferences, what I see amazing work being done. My participation is really marginal in a lot of great work that's been going on because of my primary focus on clinical care and education. But I try to participate as much as I can do, and I want to provide you an overview of what we understand about Parkinson's disease mechanisms in the brain, which is guiding therapy. This is a completely new approach for Parkinson's disease in the last few years. Heart doctors and cancer doctors have done this for decades. They were looking at what's wrong in the cell that is inside the body and what mechanisms are disrupted, and they started creating these targeted therapies for those mechanisms ground up. We have gone with what we call the evidence-based medicine, that somebody walks into a village and says everybody who is drinking milk here has Parkinson's, so milk must be causing Parkinson. Let's study a research. So then they started doing everybody drinking milk in all the state. So case who's getting Parkinson's, who's not. So that's have been the traditional approach in studying Parkinson. Observe, try to replicate, and make inferences. And a lot of trials have happened on that. So for example, the last study we did on uric acid level elevation, we observed in large population that people with Parkinson's have low uric acid level, people who don't have Parkinson's have high uric acid level. We said, okay, let's give everybody this uric acid so that the uric acid goes up, and maybe we will slow down their Parkinson, and the study failed. We end up giving a lot of kidney stones, and gout to these patients by raising the uric acid without slowing down their Parkinson's, because that's, we've been doing these observational evidence-based medicines. But the true research or true medicine, in my mind, and I've heard about it for decades, is to understand what's wrong in the cell, the actual mechanism that has gone wrong, and then create a therapy against it, just like the cancer research and just like heart research. And you will see some of the details that I will share are as amazing and complex as a cancer patient or as a cancer that's out there. And we're just beginning to understand these mechanisms. Now, the caveat is, the disclaimer is that this is a very complex talk. I will try to simplify it as much as I can, but apologize, if some things don't make sense. I also want to make a disclaimer that a lot of things I say will not be exactly true, because I have to simplify things, and one of the problems in simplifying things is that you lose precision, you lose the accuracy, but I'll try to make it as true as possible. But if you misunderstand something, I apologize for that too. All right, so with that background and disclaimers, in the next 20 minutes or so, let me try to summarize all that we know about Parkinson's. I would like to dedicate this talk to memory of my father, who wanted me to do more and more teaching and put me on this path. If you search this online database of registered ongoing trials in Parkinson's, called clinicaltrials.gov, there are over 2,000 currently ongoing Parkinson's disease trials registered on this website. And this website doesn't typically register the trials that are done in-house, within department, by fellows and students, so there's thousands of those too. In last year alone, in 2018, there were 7,822 papers published on Parkinson's in 1 year. And you can see that on this graph here, that in 1865, the Parkinson's was named, 1960, levodopa was discovered, and how the research has just taken up. And it's algorithmically just growing and growing, doubling, every few years or so, and you can see where it will head. That usually, I think, is a sign that a breakthrough is coming, this picking up of this huge amount of research, which also gives me hope. So research questions in Parkinson's disease are of many different types. I will not be able to address all those types of Parkinson's questions. So for example, there is a research on better diagnosis and monitoring of Parkinson's disease, which has been one of my interests, is how can we detect Parkinson's better? There have been studies that if you wear a watch, the watch can pick up a decrease in arm swing years before the actual diagnosis is made. They are looking at other wearable devices for Parkinson's. And then when we give medication to Parkinson's patients, they go home and they come back 3 months later and they give us an average of 3 months, say, oh yeah, I felt better. But we don't have the precise detail of what got better, what part of the day. So we're using these wearable devices at home to monitor 24/7 to see what happened at 5:15 a.m., what happened at 5:30 a.m., what happened at 5:45, and that kind of detail will be useful in better treatment and better diagnosis of Parkinson's, and so on and so forth. The other interesting topic for us in University of Nebraska is what we call neuroprotection. Neuroprotection meaning saving those brain cells that are dying slowly in Parkinson's disease patient. So that's what we meant by slowing the disease, that's what we meant by stopping the progression, is that if we can save those brain cells that are dying from dying at that rapid pace, then we will have not increase in symptoms. And then there are a lot of drug trials, which I have just one line for, which are these dozens and dozens of drugs that were listed by Dr. Torres. All these drugs improve the symptoms of Parkinson's without affecting the rate of progression. And we have had, in the last few years, a small interest in that area, just because we have been focusing and moving our resources to the first two questions, which are much more important to us. How can we diagnose better and monitor better a Parkinson's patient? How can we slow down disease and stop the progression? So we do a little bit of that, but as little as possible, not a whole lot. So this is an example. This is a wearable device. Dr. Torres has introduced this in use in our movement disorder clinic. It's called PKG, a personal kinetograph, and you can see that there is a mobility graph on better and worse mobility on this scale in the green line up top, where you can see that there are good times and bad times, And the red lines on the graph, it's one day, 7 a.m. to all the way to 9 p.m. And the red lines are the timing of medications. You can literally time improvement half hour or hour after taking the medication. This is how accurate, useful, and reliable these medications are. This amount of information is so hard to track by the patient themselves. And of course, they cannot memorize it and report it on the next patient visit. So we can do such a recording and see what happens in the day during every hour or half hour of the day. And similarly, there are other wearable devices. We partner with UNO on studying this other device called Actigraph and looking at walking, gait distribution, gait severity, changes with time, risk of falls, and things like that. Again, these markers of activity and pattern over our few-minute walk, few-hour walk, or few days of wearing of this activity to monitor that. We also have been studying effect on driving by driving sensors. We have this simulation driving, a real car fitted with over 300 sensors where you can drive on a screen and it looks like a real driving car. We have also done a study where we fitted a black box GPS kind of a device in our patients who just drove normally for a month, and we picked up the driving patterns, the speed, the acceleration, deceleration, risk of accidents, and things like that. And we have this 10,000 patient hours driving data in Parkinson that we now need to analyze, set down. Each hour is another 100,000 data point. So it's billions of data points we're talking about. We're talking about Google and Amazon level of data analysis, and you need very powerful machines and still a lot of patience to actually do it. So the second important question that we have been dealing with is how can we slow down Parkinson's disease? So just a recap that this is a part of the base of the brain, what we call brainstem. There are two sections from two different brains. The top brain is the normal one. You see two dark black lines. We call them black substance, substantia nigra. And these black substance is the healthy brain, and it's the brain cells that are dying slowly. It's black because it contains the iron, melanin pigment, same thing that darkens your skin. And these cells are important to make that dopamine in the brain. And in the bottom brain is a Parkinson's brain where you can see that most of those dark lines are gone. And that's the loss of those cells that we're trying to predict. This is what these cells look like at a microscopic level. You can see the pigment melanin pointed out. It stains brown like an iron. And then you have the cell body. And then the pink large big halo that you see on the picture is the abnormality. It's the Lewy body, which is the diagnostic of Parkinson's disease. So when we say the diagnosis is only possible at autopsy, these are the pink substances in the dopamine neurons are what we're looking for to confirm, yes, this was Parkinson's disease or not. So if the Lewy bodies are present, then we say, okay, yes, this was Parkinson's disease. So the questions are that how does these Lewy bodies form, and how do they injure the cell so that the cell results in a death, and what we can do to protect them. The Lewy bodies spread through the brain, so they start at the bottom of the brain, gradually go to the middle, and then to the top, and that's why we see dementias and hallucinations and psychosis. And now we're thinking that Lewy bodies may even start in the gut and then gradually go to the brain through the nerve-gut connection.